this is my nightmare as a cataract surgeon, and I think most of us see this. The most feared complication for me are the complaint of a patient coming post-operative after you do an excellent surgery, is coming saying that my eye is burning, it's hurting, it's red, I'm tearing, and usually they present 2 weeks after surgery, after you do an excellent surgery, and they say, typically, I wish I didn't do the surgery. Although they say I see very good vision, but I don't care. So we can induce dry eye, and we can exacerbate dry eye from our cataract surgery. There are so many different mechanisms, from the preoperative eye drops we use, dilating drops, length of time, incisions, size, so many factors that we induce, as well as the post-operative treatment, particularly with a lot of preservatives. So we should evaluate the case properly before the surgery. And I just want to share with you many examples. Many of the patients are asymptomatic, although they can have the disease and are asymptomatic preoperative. So it's very important that we really examine the patient, and we discuss with the patient who is coming to do surgery that he should be treated. Many of us or our colleagues, they rush into doing the case because they're afraid somebody else will do it, but I think you can regret it. And we can see many examples. And this is a case of floppy eye syndrome. You have to think, when you see the patient, don't look only to the cataract. You have to evaluate the eyelids, you have to evaluate the ocular surface. This will be the main thing that is going to make you hate yourself. This is the patient, he should smile, but this is after treatment. You see, this is on the right. He came asking for surgery, and this was the appearance of meibomian gland dysfunction, redness, and he never had treatment. So after treatment, after 2 weeks, I did him the surgery, and this was how he looked after surgery. The eye is quiet, the patient is happy, I am happy. So this is another example, a case that had meibomian gland dysfunction with lead telangiectasia. The left eye is pseudophakic, and her MHD, she's a chronic patient. And after doing the cataract surgery, as you can see in the upper left slide, it was grade 2 meibomian gland dysfunction. And in the lower slide, it became in the eye. I'm comparing the right eye to the left eye. She did left cataract surgery. The right eye was grade 2, and the left eye was as well before the surgery. And after the surgery, the eye that was operated got worsened. So you have to be careful. These patients will complain very much. Again, this is another case coming asking for cataract surgery. You have to identify what is going on with her ocular surface and start treatment. Examine the patient. The basic is fluorescein staining of the cornea. You can really identify that there is low tear film strip, punctate epithelial staining, and these patients don't rush to do surgery. So we did him meibography pre-operatively, and you can see how much he's affected, and the tear breakup time. And this patient, I told him, you have to take treatment. And I asked our colleague, the professional one, Dr. Samar Saadani, to do him. We have a MeiboFlow. This is one of the machines, very simple, very cost effective. And she can use certain amount of energy. She can do the massage of the meibomian glands, heat it, and then express manually the meibomian glands. This is a very simple thing. You have to tell the patient. Sometimes we are afraid to ask the patient to do any other procedure before the cataract surgery, fearing of the cost. But you are going to regret if you don't manage the patient, either medically or if you need some interference, whatever type. This is what we have available. So you can see it's a slit lamp procedure. And this is the manual expression. And this is the same patient, how the tear film improved post-operative, post-managing of the meibomian gland dysfunction, and then you can operate safely on the patient. And the patient have proved that he has a problem pre-operatively, so when he comes later on, you can, and he has a problem, you can tell him that this was already an existing problem. This patient was not actually treated properly pre-operatively, so he came, you see, crystal clear cornea, 20/20 vision, but is completely unhappy. So you start the cycle from here, but the patient will always blame you that you did him the problem. So in conclusion, dry eye disease is a complex disease, or ocular surface disease is a complex disease. It has major impacts in cataract surgery and of course other anterior segment surgeries, and it should be addressed properly to have a happy patient and a happy doctor. Actually, one of the routine preoperative exams now that we started to ask routinely is to do meibography and non-invasive tear breakup time. We added to the list of investigation, preoperative investigations for cataract surgery. Thank you for your attention.